Hello and welcome again to the GPnotebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. I'm Roger Henderson. I'm a GP and I also co-host the GPnotebook study groups. Now in this episode we're going to be discussing post-traumatic stress disorder, PTSD, which is a debilitating mental health condition that arises following exposure to trauma. And in this sense, trauma refers to actual or threatened death, serious injury, or sexual violence. Now, whilst exposure to such events can be relatively common in the general population, only a subset of individuals go on to develop PTSD. So a crucial point here is that what distinguishes PTSD isn't the actual traumatic experience itself, but rather the persistence of maladaptive psychological, neurobiological and behavioural responses that then interfere significantly with daily life. The disorder is characterised by intrusive recollections of the event, avoidance of trauma-related stimuli, negative alterations in cognition and mood, and heightened arousal and reactivity. And in this podcast, I'm going to be focusing mainly on adult rather than childhood PTSD. Now, up to 3% of adults have PTSD at any one time, and lifetime prevalence rates vary between 1.9 to 8.8%. However, rates are much higher in certain particular groups. So, for instance, combat veterans, survivors of interpersonal violence, refugees, and first responders can all show prevalence rates ranging between 15 to 30%. And women in particular are at greater risk than men, both because of a greater likelihood of exposure to certain trauma types, such as sexual assault, and because of biological and psychosocial vulnerability factors. Psychological vulnerabilities, including a history of prior psychiatric illness, trauma in early life, or maladaptive coping strategies, all also increase the risk. And social factors such as a lack of support after trauma, ongoing stress, or even stigmatization may contribute significantly. Now, at this point, I do think it's worth touching on a little bit of history, as the recognition of trauma-related psychopathology significantly predates modern psychiatry. So, during the American Civil War, for example, the term soldier's heart was used to describe a syndrome of palpitations, shortness of breath, and anxiety in soldiers. Then, in the First World War, the term shell shock captured the combination of psychological distress and somatic symptoms experienced by troops exposed to prolonged bombardment, and in fact led many unfortunate and completely innocent men to be shot as cowards or deserters by being unable to face any more trauma in the trenches. Later, during the Second World War, clinicians then started to use the term combat or battle fatigue. But it wasn't until 1980, with the publication of the third edition of the Diagnostic and Statistical Manual of Mental Disorders, DSM-3, that PTSD was formally recognized as a distinct psychiatric disorder. And this was due in large part to advocacy by Vietnam War veterans, many of whom had significant PTSD, as well as the growing body of research into the long-term psychological effects of trauma. DSM-5, published in 2013, then further refined this concept, moving PTSD out of the category of anxiety disorders and placing it under a newly created section entitled Trauma and Stressor-Related Disorders. Now, I think PTSD is best understood thinking through a biopsychosocial framework. So trauma is a necessary but not sufficient cause, as most of us who are exposed to trauma simply don't develop PTSD in any form. Instead, its emergence depends on an interaction between the severity and the nature of the trauma, each individual's biological predisposition, their psychological coping mechanisms, and the social context in which the trauma occurs. Now, from a biological perspective, this suggests a hypersensitive negative feedback loop that may impair the body's ability to contain the normal stress response. So if we look at DSM-5, according to this, the diagnosis of PTSD requires exposure to a traumatic event, either through direct experience, witnessing trauma to others, learning that a close family member or friend has been exposed, or through repeated or extreme exposure to aversive details of trauma, as occurs in first responders. Now, symptoms of PTSD are typically grouped into 4 clusters. The first cluster, intrusion, includes distressing memories, flashbacks, and nightmares that recreate the traumatic event itself. The second is avoidance and refers to efforts to avoid reminders of the trauma, either external reminders such as people and places, or internal reminders such as thoughts and feelings. The third cluster encompasses negative alterations in cognition and mood, such as persistent guilt, shame, distorted blame of self or others, emotional numbing, detachment from others, and an inability to recall aspects of the event. The fourth cluster consists of alterations in arousal and reactivity, and this includes hypervigilance, exaggerated startle responses, irritability, angry outbursts, reckless or self-destructive behavior, and disturbed sleep. Now, these symptoms must persist for more than 1 month, and they must cause significant distress or impairment in social, occupational, or other areas of functioning. Now, I say this because if symptoms occur within the first month following trauma, the diagnosis of acute stress disorder should be considered instead. So the clinical presentation of PTSD is both diverse and nuanced, and this reflects the wide range of traumatic exposures that can precipitate it and the variability in individuals' responses. Now, although the DSM-5 criteria provide a framework for diagnosis, as we all know in our surgeries, patients rarely present to us with a nice, neatly packaged set of symptoms where we can instantly diagnose PTSD in them. Instead, they often come to our medical attention with complaints that at first glance may appear completely unrelated to trauma. So let's look at these presentations in a bit more detail. And one of the most common here is intrusive symptoms. Patients may report frequent, distressing recollections of the traumatic event that intrudes into their daily life, and these can manifest as flashbacks, where the person feels as if the trauma is happening again, complete with all the emotional and physiological arousal they originally experienced. Nightmares are another prominent feature in people with PTSD, and these are often vivid, sometimes repetitive, and cause significant sleep disruption. For some individuals, even subtle reminders, such as a particular sound, a smell, or even a date on a calendar, can trigger overwhelming distress or panic, accompanied by palpitations, sweating, trembling, or shortness of breath. The second major feature of presentation I mentioned is avoidance. Patients with PTSD frequently describe going to great lengths to avoid places, conversations, or activities that might evoke memories of the trauma. So, a soldier returning from combat might refuse to watch news reports about war or decline invitations to fireworks displays as the sounds evoke battlefield memories. Survivors of interpersonal violence may avoid certain towns or cities, or even suppress thoughts and emotions related to their trauma, creating a kind of emotional numbing. And this avoidance, while initially appearing to be protective, unfortunately tends to perpetuate their symptoms by preventing natural recovery processes. Negative alterations in cognition and mood also form another central part of the clinical presentation in PTSD. Patients often may describe themselves as feeling detached or estranged from others, unable to experience positive emotions such as love or joy. And many will harbour persistent negative beliefs about themselves or others or even the world. So a survivor of a car crash might say, I should have died. It's my fault I lived, reflecting deep-seated guilt or shame. Others might express a sense of a foreshortened future, saying things like, I don't expect to be around much longer, or I can't imagine having children. And cognitive difficulties are also common, including problems with concentration, memory, and decision making, which can all lead to occupational impairment. The final cluster of symptoms I touched on involves arousal and reactivity. And I've found when talking to patients with PTSD that hypervigilance is a rarely frequent complaint, with patients constantly feeling on edge and scanning their environment for threats. And this is often coupled with an exaggerated startle response, so that an unexpected noise or movement can provoke intense fear. Irritability and anger outbursts are common, sometimes leading to strained family relationships or workplace difficulties, and sleep disturbance is almost universal, encompassing both difficulty falling asleep due to the hyperarousal and then frequent nighttime waking due to nightmares. Some patients may find they engage in reckless or self-destructive behaviors such as substance misuse, dangerous driving, or risky sexual activity, all as a way of coping with distress or attempting to regain a sense of control. Now, I think it should be obvious from what I've said that the overall impact of PTSD on daily functioning is absolutely profound. Individuals who have it often describe being able to sustain employment, pursue any education, or maintain healthy relationships. And social withdrawal can be marked, with patients avoiding gatherings, becoming isolated from friends and family, and sometimes even living in near complete seclusion. PTSD also carries a very high risk of comorbidities, so depression is common and often severe, with many patients reporting hopelessness and anhedonia. Substance use is unfortunately frequent, as individuals attempt to self-medicate intrusive memories or their insomnia with alcohol, cannabis, or sedatives. And physical symptoms are often very prominent, so chronic pain, gut complaints, and headaches may bring patients first to us as GPs rather than mental health services. Presentation of PTSD does appear to vary with age. So in children, PTSD may manifest not as verbalized flashbacks, but through repetitive play that reenacts aspects of their trauma, or through frightening dreams that may not have any identifiable content. Adolescents may present with irritability, aggression, and risk-taking behaviors, all of which may be misattributed to normal teenage rebellion. And then in older adults, symptoms may resurface decades after trauma exposure, especially when retirement or bereavement or medical illness removes their coping mechanisms or reactivates old memories. And finally, I think it is worth emphasizing the heterogeneity of presentations. Now, while some patients may actually exhibit all 4 symptom clusters very vividly, others may present primarily with sleep problems, irritability, or highly vague somatic complaints. Stigma or shame or even dissociation may prevent our patients from disclosing any history of trauma unless carefully and sensitively inquired about. And so for this reason, as GPs, I do feel we should maintain a high index of awareness about possible PTSD in any patient who has undergone a major traumatic event. Now, obviously, our assessment needs to be comprehensive, combining a detailed trauma history with structured clinical interviews. And the CAPS scale, the Clinician Administered PTSD scale, is considered to be the gold standard here. But self-reporting measures, such as the PTSD checklist for DCM-5, called PCL-5, or the impact of event scale, can provide valuable screening tools. Importantly, assessment must also evaluate comorbid psychiatric disorders, substance abuse, and the risk of self-harm. Fortunately, the treatment of PTSD has advanced considerably in recent decades, and evidence now strongly supports the use of trauma-focused psychotherapies as first-line interventions. Trauma-focused CBT helps patients identify and reframe their maladaptive beliefs, to confront avoided trauma memories, and to reduce their emotional distress. Prolonged exposure therapy systematically confronts trauma-related memories and situations, allowing the extinction of fear responses over time. And EMDR, or eye movement desensitization and reprocessing, uses bilateral stimulation whilst recalling traumatic memories, facilitating reprocessing and integration. Pharmacological treatment is also important, especially when psychotherapy alone is insufficient or inaccessible. But a really important point here is that we should not offer drug treatments, including benzodiazepines, to prevent PTSD in adults. Selective serotonin reuptake inhibitors, such as sertraline, paroxetine, and fluoxetine, as well as the serotonin norepinephrine reuptake inhibitor venlafaxine, are the only medications with robust evidence and approval for PTSD. You can consider antipsychotics, but these should only be commenced by a specialist in addition to psychological therapies to manage symptoms for adults with PTSD if they have disabling symptoms and behavior, and these symptoms have not responded to other drug or psychological treatments. Overall, the best outcomes are often achieved through combined approaches, integrating psychotherapy with pharmacotherapy, particularly in individuals with severe or chronic symptoms, and any treatment benefit doesn't appear to decline with the passage of time since the traumatic event that triggered the PTSD. If we look at prognosis, then the course of PTSD is highly variable. Many individuals can experience spontaneous remission, whilst others may suffer for the rest of their life. Chronic PTSD is associated with poor quality of life, impaired occupational function, strained relationships, and an increased risk of conditions such as cardiovascular disease. Factors predicting poor outcome include exposure to severe or prolonged trauma, multiple traumas, early trauma onset, comorbid psychiatric disorders, and lack of social support. Now, the severity of symptoms 2 weeks after the trauma is a good predictor of the degree of severity at 6 months. On the other hand, a strong family and community support, Early recognition and prompt treatment all improve the likelihood of recovery. So I do hope you found that quick overview of PTSD helpful, but have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you consider following the podcast and leaving us a review on your favourite podcast platform. Feel free to get in touch via social media at GPnotebook or email us support@GPnotebook.com if you have any questions, comments, or even ideas for future podcasts, as we do really love to hear from you. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups, which occur all year round, and to download free shortcuts to help improve the lives of our patients in primary care. But, as always, until the next time, thank you for listening, and goodbye.